Manchester, primarily in the community, working in sexual and reproductive health. So my talk today is on contraception, an overview of contraception, and then just some kind of specific conditions for people with cardiac conditions. So hopefully today I'll just go over kind of why contraception is important, different methods of contraception that are available, and the considerations we may need to make for people with cardiac conditions. We had a bit of a Q&A about what people would find helpful in these sessions, and I think some people spoke about how to manage side effects or experience with contraception, so I'll cover that a little bit. Contraception planning during pregnancy, and then also a bit about managing unintended pregnancy as well. And I'm very happy to answer any questions at the end. So why is contraception important? So we know that it reduces the rates of unintended pregnancy, and it allows people to plan when they want to have a baby, if they want to have a baby, but it does have other benefits as well outside of its kind of contraceptive covers. So it can help with symptom control, so it can help patients with heavy painful periods, endometriosis, PCOS, and it can also help in disease prevention. So we know that certain types of contraception may reduce risk of certain types of cancer, and be really beneficial. In terms of people who its role in preventing pregnancy, more specific to these talks today, we know that a shorter inter-pregnancy interval increases risks to baby, and in mothers over the age of 35 increases risks to mum as well. So we really should be utilising contraception, because contraception helps us with pregnancy planning and spacing of pregnancy as well. And then more specific for this talk, so what considerations do we need to make for people with cardiac conditions? Why is contraception important? Now, I have no background in cardiology, but from a contraception perspective, I'm aware that the risk kind of varies widely, and it depends on an individual's cardiac diagnosis and their individual risk factors. And I'm not going over kind of specific conditions in this talk, so it is just more of a general overview. But we know that increasing numbers of people of reproductive age are affected by cardiac disease, and we know that pregnancy can increase cardiovascular risk and increase symptoms that someone may experience from their cardiac condition. When we're talking about contraception with people with cardiac conditions, we always need to consider what their preferred method of contraception is and what they want, but we should also think about the risk to the individual if they were to become pregnant, and then the risk of using this method of contraception, including the risk of administering it, so fitting an implant or fitting a coil, but also the risks of using the method, and then weighing that up against the benefits of using a method. We would advise that kind of in terms of when to talk to people about contraception, I mean, our faculty advice would be recommended that those conversations kind of start depending on an individual's maturity around the age of 12 to 15. In sexual health services, we do see people at young ages, but I understand sometimes it can be difficult having conversations with people, younger people, especially kind of around the age of 13, 14, 15, but it is important to have these conversations, but it's just a case-by-case basis dependent on the patient who's in front of you. It's difficult because evidence, is quite limited regarding how safe contraception is, and the risk of using a method of contraception in a healthy patient may pose a much more significant risk in a person who has cardiac conditions. So I thought it would hopefully be useful just to go over a brief overview of the different types of contraception. The slides are quite wordy, and I won't go over everything kind of word for word, but sometimes it is useful just to have a bit of a refresher of the different types of contraception that are available, and then also what considerations we may need to make for people with cardiac conditions. So starting off with the hormonal coil, you may have heard of this as the IUS. We're kind of moving away from the term IUS and calling it the levonorgestrel IUD. Some people also use kind of brand names, so the Mirena, but there are different types of hormonal coil. There isn't just the Mirena, so it's best to kind of avoid using brand names. But essentially, it's a hormonal device that sits within the womb, releases a very small amount of progestogen, and it works as a contraceptive by thickening the mucus at the cervix to stop sperm from getting through. But we know that it also thins the lining of the womb, so that's why it also comes with a great non-contraceptive benefit that for many people it stops or dramatically lightens their periods, so it can really help with people who are suffering with heavy painful periods. We know that it's a LARC, so it's not dependent, it's not a user-dependent method, it lasts for a long time, so it's a really good, reliable form of contraception. Then we have the copper coil, which it's also a device that sits within the uterus. It doesn't produce any hormone. It's got copper wiring on the body and sometimes on the arms as well. And it works because copper is toxic to sperm, so it stops sperm and eggs from meeting. Again, it's a longer acting reversible form of contraception. It's not user dependent, so it's much more reliable method of contraception. And it can last for up to 10 years, depending on the device, but sometimes we use a 5-year device as well. One of the potential side effects with the copper coil is that it can make periods heavier, more painful and longer, so it may not be ideal for someone who already struggles with their periods, but it's a good option. There's some patients who wish to avoid hormonal contraception, so it may be a good option for them. So when we're thinking about coils with patients with cardiac conditions, what kind of things do we need to think about? So during the procedure of fitting a coil, obviously it includes touching and manipulating the cervix, and sometimes cervical stimulation can cause a vasovagal reaction, it can cause bradycardia or other arrhythmias, and some people with cardiac conditions may not respond to kind of the standard treatment measures that we have available to us in clinic. Often, we're often in community clinic, even if we're on a hospital site, we might not have access to the crash team, and we only really carry kind of oxygen and atropine. We don't really have kind of anything else on top of that. And sometimes if we do ring for ambulances because the person is technically in a safe place, we're kind of bumped down the priority list, even though it's not always an appropriate place to manage if a patient does have an adverse reaction to coil insertion. So for that reason, we may liaise with an individual's cardiologist, and we do that sometimes, just to ask for their advice about their individual condition and whether they feel that this patient would be able to tolerate coil insertion, or whether it's safer to be done in a hospital, and we can arrange for coil insertion to be done in a hospital. Other considerations, so I know that prophylactic antibiotics are no longer routinely required for lots of procedures now, but there's some patients with high risk cardiac conditions for infective endocarditis where we may want to speak to the cardiologist first. We also need to consider bleeding risks if patients are on anticoagulation or antiplatelets, but generally these patients are safe to have their coil fitted in the community with us. We just maybe need to time the insertion at the time when their anticoagulant is having the lowest effect, or if they're on warfarin, we might need to check the INR within a few days before the procedure, but generally we're happy to fit those in the community, and we just might want to monitor them afterwards. So next we have the implant, so another LARC, so a longer acting reversible contraceptive. So that's the plastic device that sits within the arm, and it releases the hormone progestogen, so it prevents ovulation. It's the most effective form of contraception, so if you've got someone who's really anxious about getting pregnant or who wants the most effective, then the implant would be the best one to offer for them. It lasts for 3 years. It can sometimes help people with heavy painful periods, but it does come with a potential for an unpredictable bleeding pattern. So that's just something to discuss with patients. It's not as reliable as the hormonal coil at helping with dysfunctional bleeding. There's not really any considerations that we need to make for people with cardiac conditions. It's generally a safe and effective form of contraception. Just again, we may need to time it with their anticoagulation or antiplatelets, and we may just need to monitor them in clinic afterwards just for bleeding from the insertion site, but that's very uncommon and unlikely to happen. In patients with ischemic heart disease, it's safe to use. However, if they have if their ischemic heart disease, if the onset happens with an implant in situ, we would recommend removing it and switching to another method of contraception. And then we've got the progesterone-only injectable, which you may have heard of as called the depot injection. So it's an injection of a progesterone. It's quite a high dose of progesterone, and it can be given in clinic or by GPs, usually given as an IM injection into the bottom, but it could also be given as a subcut injection, and the patient has the option to do it at home as well. We have Sian Press, which they can do at home. It prevents ovulation. It's very effective if used perfectly, but because it is more user dependent, they have to take it every 13 weeks, then typical use is a bit less effective, more like 94%. It can help with heavy painful periods. Around 50%, just under 50% of people report no periods or just light spotting with it after the first year of use. But it does have some specific side effects. So it can cause weight gain, it can cause osteoporosis, it can cause thinning of the bones, but that's likely to be only a small reduction in bone mineral density, and it can delay fertility. So it's not ideal in someone who is planning a pregnancy in the near future. Because it's a very high dose of progesterone, it may cause an increase in lipids, and it may also cause weight gain. So again, in people with multiple risk factors for cardiovascular disease or existing vascular disease or ischemic heart disease, then it's not recommended, and we would want to think about other methods of contraception. I know that in patients with congenital heart disease, if we have a patient under the age of 18, we can use the depot, but because of that, if they've potentially not reached their kind of peak bone mass, it may be better to think about the other options before we settle for the depot. But if they're absolutely adamant that this is the only thing that they want to try and they have no other contraindications, then it can be given. But we would want to think about other options because of that effect on the bone. And it also may not be desirable for patients. If they're not wanting to do self-injections, then they're having to attend every kind of 10 to 14 weeks, depending on the type of progesterone. And if they're already having a fair number of appointments, then they may not want to come back for more appointments. And we've got the progesterone-only pill, or the mini pill, which is the pill that contains progesterone only, works by suppressing ovulation. It's a very good, generally very safe method, but the downside is that it is reliant on the person remembering to take it at the same time every day. So it's less, with typical use, it's less effective than the other methods. And generally it's safe and it's an effective form of contraception. So there's no one with, it's very rare that we see someone who has a condition that would preclude the use of the progesterone-only pill. But the downside is that if we have someone where pregnancy, would confer quite high risk, then we would want to be recommending a LARC over a user-dependent method like the progesterone-only pill. And then we have the combined hormonal options. So we've got the pills, the patch or the ring containing estrogen and progesterone. It does have benefits in that it can help with heavy painful periods. It can also help with PMS, PMDD, and it can give users quite predictable bleeding pattern. But it does have some potential side effects and also risks. So we know that it increases the risk of certain types of cancer, and it does increase the risk of both venous and arterial thromboembolism. So it may not be recommended for patients with ischemic heart disease or those with risk factors. Or patients who are already at increased risk from thrombosis due to arrhythmia or anatomical variants. And then just when talking about contraception, always remember, so we have the UK MEC. It's not exhaustive, but it is a really good tool to have a look at a patient's individual characteristics or medical conditions and see whether a method of contraception would be safe. So that's for, I know I've talked about cardiac in relation to patients with cardiac conditions, but also if they have any other medical conditions to always check. And it gives a score from 1 to 4. So, and 1 is no restrictions, there's no risks, to 4 where the risks far outweigh the contraceptive benefits of using this method of contraception. So managing side effects, I think the main thing to say is that if you have a patient who's struggling with side effects with any form of contraception, we would always be happy to see them in sexual health clinics, and they can speak to their GP. It's common to experience side effects with hormonal contraception, and that may be side effects of things like the hormonal side effects of things like mood changes, skin changes, breast tenderness. If they can tolerate it, they would usually, we kind of see if people can manage for about 3 months and they may settle. But kind of one of the more common reasons people come back with side effects is because of the bleeding pattern. And I think I wouldn't expect these to be managed outside of the GP setting or sexual health setting, because what we need to do is we need to make sure that we're excluding other causes of bleeding. So before we just put it down to their method of contraception, we need to exclude pregnancy, exclude infection, make sure that they're up to date with their cervical screening and that we've checked their cervix. So, and we would always be happy to see patients and do that here. Once we have excluded other causes, then we can manage bleeding, and that may include using the combined pill if they're eligible on top of a coil or an implant, for example. The progesterone-only pill can sometimes be used, or using things like mefenamic acid and tranexamic acid can sometimes help settle the bleeding down. But you can kind of reassure patients that if they can tolerate the bleeding with oral contraceptives and the implant, we'd say try and give it kind of 3 to 6 months to see if it settles. Bleeding with the injection or coils, maybe give it kind of 6 to 9 months to see if it settles. But there are things that can be done, and of course they can always stop this method or switch to another method of contraception. There's no evidence that bleeding with one type of progestogen or hormonal contraception means that they're going to have the same with another, so they can always try something else. This is just, it's not projected very well, but it's just a bit of a flow chart on our faculty website, so the FSRH website, about discussing contraception with women with cardiac disease, if that might be something that you find useful. Again, I think there was a question about contraception considerations prior to surgery. So a few things just to be aware of. So if you've got a patient who's using combined hormonal contraception, because of the VTE risk, that needs to be stopped at least 4 weeks before planned surgery, and then they can start it again 2 weeks after they've mobilised. Not all surgery is planned, so if there's any emergency surgery, then they need to have their full kind of thromboprophylaxis assessment, and it would be advised if they've been taking combined contraception. Progesterone-only contraceptions can be continued, but just be aware that if a patient is in the hospital and having surgery, they may not have, if they've not taken their progesterone-only pill when they should have done if they've been missed pills, then they would have to follow their missed pill guidelines. Bariatric surgery, weight loss surgery, can reduce the effectiveness of oral contraception, and just as on top of that, whether it's something that you've seen in your practice, we've started to see quite a bit of it trickling through now, is patients who are taking things like Mounjaro or semaglutide, Ozempic. There is new evidence to suggest that that can also reduce the effectiveness of oral contraception. So just something to be aware of. It's something that we're starting to become aware and seeing in clinic now. And then transplantation. So if someone's really keen for a coil, it would become a UK MEC3 after a transplant procedure. So, but it's a UK MEC2 prior to transplant, so just something to bear in mind. And then there are some potential drug interactions. So similar to the Mounjaro and Ozempic I mentioned, some of the drugs used by anaesthetists can affect the efficacy of hormonal contraception as well. Contraception planning during pregnancy, so it should be discussed with all women kind of throughout pregnancy, because people should be made aware of the risks of a very shortened pregnancy interval. So we would kind of advise spacing pregnancies, and also I think that a lot of people aren't aware of how quickly they can get pregnant after having a baby. So if they're not fulfilling the lactational amenorrheic method, which is exclusively breastfeeding, which is every 4 hours during the day, every 6 hours at night, not having a period, and within 6 months of birth, which a lot of people aren't fulfilling those rules, then the fertility can come back as soon as 21 days. So when we tell people to discuss their contraception choices with their GP at their 6 to 8 week check, it could potentially be too late. So it's really important to have the conversations throughout and also before they leave hospital. All forms of progestogen-only contraception can be initiated immediately after giving birth. So that could be facilitated on the postnatal ward, and if that's if a plan is made before birth, then that just makes that even easier to facilitate. Coils can be inserted at cesarean birth. Post-vaginal birth, there's a small window, 48 hours, but after that, insertion can be delayed until 4 weeks. Has to be delayed until 4 weeks. But we know that kind of continuation rates are much higher when contraception is started as soon as possible after birth. And unsurprisingly, people who've just had a baby, the DNA rate is much higher if we're asking them to come back at an interval rather than being able to facilitate contraception immediately. Managing unintended pregnancy. So you may come across people who are pregnant and not sure if they want to continue with the pregnancy or whether they want to have an abortion, whether it's for reasons outside of their cardiac condition, or whether they're unsure that whether they feel like they should have an abortion because of their cardiac condition. So these patients should be seen urgently and to discuss options with them. And then in terms of the procedure, it would depend on cardiac condition and gestation as well. And it should be, if they've decided they want to go ahead with termination, then they should be referred, and that should be performed as soon as possible. But yeah, the method of abortion will depend on a variety of factors. So sorry, I thought I added a slide there. So in conclusion, so we know that contraception offers reproductive autonomy to allow pregnancy planning, but there's also lots of other benefits for contraception as well. It's important to discuss contraception to reduce the risk of unintended pregnancy, especially if pregnancy would put an individual at risk. People should be made aware of all the available methods of contraception and how to access them. And for some patients, provision of contraception may be a multidisciplinary approach. We may need input from an individual's cardiologist and vice versa. But generally speaking, we could offer something like the progestogen-only pill as a bridging method while we're having these discussions to make sure that the patient is covered. And then I think we're doing questions all together at the end. So yeah, thank you very much for listening.
Thank you, Sian. That was really informative and covered lots of different elements for people to consider. And I just want to reaffirm that we're going to do Q&As at the end. Please feel free to put any in the chat or the Q&A section of the webinar as well, and we can pick those up at the end. But I'm going to hand you over to Dr. Anna Roberts now, and we'll go straight into the second talk so that we've got enough time at the end for question and answers as well. Dr. Anna Roberts is the Consultant Obstetrician at St Mary's Hospital in Manchester, and she's the lead for the obstetric cardiac service over there. So I'll let Anna just introduce herself in a bit more detail, and we look forward to your talk, Anna. Thank you. I think you're muted, Anna. You're still muted, Anna.
Okay, I think I'm not muted now. Can you hear me?
Yeah, that's it. You're great now.
But can you see my slides?
We can see it in presenter mode. You just need to go into slideshow.
Yeah. Can you see
there you go. Yeah,
excellent.
All good.
Okay, thank you. So yeah, as Linda said, I'm Anna Roberts. I'm a consultant obstetrician at St Mary's Hospital, which is in Manchester. I'm the lead for the obstetric cardiology service here. So a bit of an overview of what I'm going to cover today. Is quite a short slot, and there's a lot of detail that we could cover, so I'm not going to attempt to cover everything or talk about specific conditions, but just to give you an overview of the sort of principles of managing congenital heart disease in pregnancy. So we're going to cover a little bit about preconception conversations, about how you can stratify risk, and how to get support with stratifying risk in pregnancy, touch upon a little bit about pregnancy and medication, cardiac medication, and then talk to you a bit about the setup of our obstetric cardiology service, what we do within it, and how we would go about planning birth. So preconception conversations, as Sian mentioned, that they recommend talking about contraception from age 12 in transition services or paediatric services. And alongside that conversation, I think mentioning pregnancy as something that women might want to do in the future is also really important. So historically, we see, or we have seen in the past, a lot of women who have been told from being a very young child, or understood from whatever source, that pregnancy is either contraindicated or carries an extremely high risk. And in many circumstances that may be true, but I think we need to ensure that the information being given to women is sort of contemporaneous. I think that in modern practice, many conditions that were seen very rarely in the past, we can now support those women to have what is often successful and healthy pregnancy. So just making sure the information we're giving is up to date, and I'll point you in the direction of some resources to check that out for yourselves. But starting that conversation early so that people don't have incorrect misconceptions, and also for those women who are at very high risk, that they're aware of that when they're formulating views about their life and their future and what they might want to do, and starting that early in sort of late childhood and early teenage years, I think is important. So starting early and mentioning it often, because whilst it might not be of interest 1 year, at the next review a year later it might be very relevant depending on changes in people's personal lives. We'd encourage people to refer for formal counselling, particularly for the more severe conditions. And again, I'll refer you to a resource to look at classification of specific conditions. But the obstetric cardiology services in the Northwest will all be able to offer formal preconception counselling, where we'll look at that woman as an individual and what her individual risk is. It's sometimes not only dependent on the cardiac condition, but also on complications in previous pregnancy if the woman has had any, on other sort of coexisting medical conditions. Things like weight and obesity can cause a huge sort of overlay of risk. So lots of things to consider, and we were able to provide that kind of overview and specific advice. So please do refer to us when women are considering a pregnancy or want to get more information. We want to encourage women to embark on pregnancy when their health is optimised. So two sort of aspects to that. One is their general health being optimised, and by that I mean really things that they can control within their own lifestyle. So if a woman is very overweight, encouraging and discussing sort of weight management prior to conception can make a massive difference to the risk in pregnancy. Obviously, smoking is always a bad idea in pregnancy, so stopping smoking in preparation for becoming pregnant, reducing or stopping alcohol intake, and also for any woman not using contraception, we would advise that they take a low dose of folic acid. So for the general population, 400 micrograms of folic acid once a day, and ideally that should be taken in the 3 months prior to conception. So anyone not using contraception should be advised to take that. It can be bought in a supermarket as part of a pre-pregnancy vitamin supplement or from the pharmacy, so it's very easy to access, and we'd continue that to 12 weeks of pregnancy. The other aspect of that sort of optimising health prior to embarking on a pregnancy is just considering pregnancy as something that might be on that woman's agenda when you're planning sort of interventions or investigations. So if a woman, for example, is coming up to the point where they may need to have an intervention, maybe a valve replacement or other surgery, is about factoring in and having a conversation with the woman about her feelings about pregnancy. Sometimes it may be safer to proceed with a pregnancy before any surgery, particularly when we talk about valves, and I don't want to get embroiled in the details of specific conditions, but the type of valve replacement that is done will have an impact on pregnancy risk. So just considering pregnancy as a factor when sort of planning care would really help. So this is a screenshot of the Northwest Maternal Medicine Network guideline for cardiology conditions in pregnancy. So I provide the link for this at the end. There's a very comprehensive guideline and a pathway that goes with it that we've worked on as part of the Northwest Maternal Medicine Network. It's based on the European Society of Cardiology guidance, but it has been edited for local purposes, and also that didn't include an awful lot of conditions. Equally, the WHO categorizations don't include some conditions which have been added here. So it's definitely a Northwest version, but this is just a way to help generalists stratify the severity of conditions and relate that to risk in pregnancy. So it's over 2 pages. This is the sort of classification. You can see the more mild conditions, such as mild pulmonary stenosis on the left-hand side of the screen, moving up to the more severe conditions, things like severe aortic stenosis, mitral stenosis, Fontan circulation, that kind of thing, are amongst the more significant conditions that we'd see. So this is the next page of the table. You can see the classification of the diseases labelled at the top, and this just gives a bit of information about what the risk would be in pregnancy. This data is lifted from the ESC guidance, and where these women should be seen in terms of referral and where they should have care in pregnancy. But I would say that there's, I'm sure you're all aware, there's such a huge individual variation even within these conditions. And I think this is a field where management should be bespoke. And it may be that we don't, it's a guideline, we don't always follow this exactly, but it's a useful guideline as to what care somebody might need and where they might need to have it. So questions that we often get asked and referrals asking for more information often focus around cardiac medications in pregnancy. So I couldn't possibly cover all medications, but I just thought I'd highlight some of the major contenders and the things that they're concerned about. So in pregnancy, we tend to avoid warfarin because of warfarin embryopathy. It is a teratogenic drug. None of these things are absolute, and in our field in particular, we're always about balancing the risks and the benefits for that individual woman. There are some services who continue warfarin for very high risk women, or use a sort of bridging method where they take them off at the beginning of pregnancy and at the end, but they continue with it in the middle. In the Northwest, we don't do that for good reasons that I won't go into now, but what we do is take people off warfarin in very early pregnancy and transfer them onto low molecular weight heparin. That's an extremely risky time in terms of risk of developing thrombus or a coagulation issue. And so it really needs to be supervised by a service that's set up to do that. We can offer that service. As soon as women become pregnant, they can contact us. We have a sort of haematology and cardiac midwifery service that will see women within a day or so and manage that crossover safely to ensure that they don't have big windows where they're poorly anticoagulated. Other medications we prefer to avoid in pregnancy. ACE inhibitors and ARBs are associated with fetal renal issues. and so we prefer to avoid those. Amiodarone may be associated with fetal thyroid toxicity. As I said, none of these are absolute. We have on occasion used amiodarone with fetal monitoring in sort of extreme situations, but as a general rule, these are the medications we would try to avoid. Just a special note on beta blockers, really. I think beta blockers are not teratogenic, so they do not cause fetal anomalies. There is a possible association with growth restriction, and that's something we're learning more about. Currently, we've got a child lecturer that works with us from the obstetric perspective in clinic, and she has done some research about beta blockers, and there's an ongoing study looking at different types of beta blockers and growth restriction, because there really isn't very good quality data to inform that. We would not take women off beta blockers as a routine situation, because often they are a medication that is having a significant beneficial impact on the cardiac disease or the other disease that the woman might have, hypertension, etc. We would offer additional growth scans to detect fetal growth restriction, but what we haven't seen so far, we don't have the evidence for, is that all women on beta blockers are having, severely growth restricted babies. That doesn't seem to be the case. It's usually safe to manage pregnancy on it. So I would urge you not to sort of take women off beta blockers when they're pregnant. It's better if they're seen in specialist service and have a discussion about that. And we would obviously make that decision in conjunction with the woman and her view. Other drugs, obviously there will, this isn't a comprehensive list, but other drugs generally continue or seek early advice if unsure about what medications can be continued and can be stopped. And the other point that I just wanted to make is generally we would continue medication until there is a positive pregnancy test. There are a few situations in which we may suggest stopping. For example, occasionally, depending on the drug and the situation, we might look at stopping and things after an embryo transfer with assisted fertility. But as a general rule, women should continue with their medication until they become pregnant, because they may be not using contraception, maybe trying to conceive, but that may take months or even years. And so if it's a beneficial drug for their general health, it's probably better for them to stay on it until a positive pregnancy test has occurred. So moving on now to talk a little bit about the service. There is an obstetric cardiology clinic, both in 3 units in the Northwest. There are also some other sort of smaller clinics, I think, run by smaller hospitals who would be maybe seeing some of the lower grade risks, but generally with congenital heart disease, we'd expect them to be seen in an obstetric cardiac centre. So we are the hub in St Mary's. We run a weekly clinic and we run the monthly regional MDT, so cases that are complex or that specific cases that have a sort of question to be answered that needs the MDT to sort of put their heads together. We discuss in that. Liverpool also bring their cases to that meeting, and we often liaise with other units for cases where the care is shared and other units are involved. We're very lucky here in that we have a co-located service. So St Mary's sits within the wider MRI. Everybody's in the same place. So we've got cardiology, we've got high level, tertiary level neonatal care, and we've got access to cardiology support and to investigations and some interventions, although not all, on the same site, which makes our job easier. Liverpool Women's also run a service and an alternate week clinic. One of our cardiologists who's not in this picture, Damien Cullington, who some of you may know and is hoping to join later, he works in both clinics, and so we do work as a sort of wider team as well. And there is also a service in Blackpool. So the picture before is our team. We've got lots of different professionals within the team. The right hand side of the screen, Jenny and Laura, who's one of the congenital heart disease nurses, and Jenny, our midwife, left-hand side of the screen some of our echo technicians who come to clinic and perform echocardiograms in a sort of one-stop shop sort of situation. So we get investigations and then we see women straight away. In the middle there, you've got a gaggle of doctors, including Sarah Vors, who has recently retired. Our approach to pregnancy with heart disease is truly a multidisciplinary approach with the woman at the centre. So on a regular basis, women will see obstetricians and cardiologists sat together in one room. We've got cardiac nurses and midwives that attend the clinic. And we've also got easy access to obstetric clinicians who are a group of doctors who are medically trained, who become experts in pregnancy. Cardiac surgeons and cardiothoracic anaesthetists, sometimes we need to liaise with them, and we do have attendance from them at our monthly MDT. Obstetric anaesthetists are key to the team really and to planning, and women can also see them at the same time in our Tuesday morning clinic. So antenatal care, we try to offer a one-stop shop, so women receive their investigations in the same location, so they have an echo, they have an ECG. If they need a fetal scan, women with congenital heart disease are all offered a fetal echocardiogram around 20 weeks, because there's obviously an increased risk of congenital heart disease in their baby, and might also need growth scanning, and that can be done at the same time. We have an anaesthetist running a clinic alongside ours, so we've got access to that support, and they're very involved in the team meetings. And the midwifery and nursing support provide some continuity and a bit of social support for the patients as well. It's bespoke responsive care based on an individual risk assessment. So whilst there are some guidelines about how often people are seen, we're often adapting that to the individual patient and seeing them on a fairly regular basis to track their progress as pregnancy progresses and the cardiac workload increases. And as part of the antenatal care, we're always thinking about planning for birth, making plans but accepting that plans can sometimes change. And on birth, one of the messages I really wanted to get across, which I think is probably a popular misconception, is that caesarean section is not necessarily mandated. There are very few cardiac conditions that mandate a caesarean section. Most women can be supported to have a normal birth. And caesarean section is not the sort of panacea for any problem in pregnancy. So conditions such as really severe aortic stenosis, caesarean section may be the safest option, but many other conditions, most other conditions, we can support women to have normal birth. And often that can be really empowering for them, women who've had very medicalised childhoods and in their young adult years with lots of intervention and medical attention and perhaps restrictions on their activity. If they are in the lower risk category and it's safe for them to go through a normal birth, then we do really try and support that, because it can be really empowering for women, and we don't want to over medicalise where that's not necessary, obviously with the caveat of that being safe. We make birth decisions alongside the woman, ultimately the choice about how she delivers is hers, and we would advise and support, but she is at the centre of any decisions made about her. Other considerations are locations of birth. So depending on the condition, we may want a woman to deliver in St Mary's, where we've got the advantage of that co-located sort of situation. Often we suggest a vaginal birth, but there are additional precautions. So we may, for example, want to shorten the amount of time that women push for, or we might want to provide some additional monitoring. They may need an arterial line, we may recommend an epidural. So these bespoke birth plans are made in the antenatal period. Postnatal care, so that obviously begins on the ward. Some women need a prolonged postnatal stay because of the sort of changes that occur around the time of birth. We usually then see women for a 6-week postnatal review, although for some of the lower risk conditions, because of capacity demands, we're sometimes referring those women back into Congenital Heart Disease Services directly for follow-up. But those postnatal visits would involve a debrief about pregnancy, and if there were any deterioration condition, about birth and their experiences of that. It would heavily focus on contraception, and we start that contraception conversation antenatally. As Sian's highlighted, that's a really key and important factor. At that postnatal appointment, we'd also be doing some preconception counselling for a potential future pregnancy. We reinstate medications with breastfeeding in mind. Many cardiac medications are safe for breastfeeding more than pregnancy. For example, ramipril and warfarin can both be used whilst breastfeeding. And then we'd arrange follow-up and sort of plug people back into their usual congenital heart disease services. So key points in summary: have conversations about pregnancy, start those early, mention them often, consider it as a factor when making sort of clinical decisions, and ask the woman about her sort of thoughts and plans. There is a large spectrum of risk, as you can see from the guideline charts. And just to remember that caesarean birth is rarely mandated, and that we can support many women to have normal births. A bit further information here. So the links there are to the regional guideline. The second line down there is a link to the online form for referral to our MFT, our Manchester-based obstetric cardiology service. The Maternal Medicine Network website has links to the individual services, so that can be accessed through their website. The ESC guidelines are useful reading if people want further information. And if anybody's particularly interested, wants to find out a bit more, then we usually have observers in clinic, so anybody is welcome to come and join us for a clinic and sit in and see what we do and how we approach things. The MDT that runs once a month on a Tuesday morning is on Teams, so we can share the link for that. If anybody wants to come along to that and learn a bit more about some complex cases, then if you contact me, I can arrange for the link to be sent to you. And we're happy to have more people on board for their education. Thank you.
Thank you, Anna. That was really informative and really clear, and I'm hoping that lots of people have got lots of questions for you in just a minute. However, I'm just going to stop recording first, so just bear with me while I turn this off.